Good morning, everyone, and welcome to this meeting of Falkirk Integrated Joint Board. Lovely to see everybody online and in person. Fortunately, it's not snowing today, so everybody got here fine. I'm just going to quickly ask for apologies, and then there's a couple of things that I'd like, and declarations of interest, and then just a couple of things I'd like to mention.
Thank you, Chair. We've had apologies from Ross McGuffey, Kenneth Laurie and Andrew Murray.
And I'll just open it up for any declarations of interest. Ian.
Thank you, Chair. Just for transparency, I have an interest at items 6 and 7 on the agenda, specifically relating to partnership funds in the budget review process. That's in my capacity as Chief Officer of FIDAM, but I would believe in my capacity here on the board that I don't need to recuse myself for those sections.
Thank you.
My name is Victoria McRae from CBS Falkirk and District, and I too have a declaration of interest, and Ian put it so eloquently that I will confirm that the same position is for myself.
Thank you very much, and that's much appreciated for that declaration. Thank you. I'd like to start the meeting with a few congratulations and good news. The Community Hospital Pharmacy team won Team of the Year at the Scottish Healthcare Awards, and I think that's fantastic news and real testament to the work of that team, so well done. And also like to mention a former Larbert High School pupil who's Jill Hendry, and she lost her sight, and she has won an Outstanding Achievement Award with Scottish Care, and she lives at Carindale. So congratulations to Jill as well, and I think again testament to all her hard work and the achievements that she had, and it's a fantastic story and a piece of information about the activity that she's been undertaking. So I'm just going to very briefly just turn off the sound on my computer because it's pinging away there. She says trying to do that. And I'll take us on to the minute. So the minute of the last meeting, which was the 27th of September, I'm not proposing to go through it page by page, but what I'll do is I will open it up for any corrections to the minute. There's none. If we are happy to approve the minute. Okay, thank you very much. I'm going to move us on to the action log. I believe all the dates and actions are up to date in terms of the timescale. I'll just check with Gail if there's anything she wants to add to it.
I think that the information has been updated, so the work around our bed-based review is ongoing. However, it's delayed also because of the work around our budget approaches and savings. And there's other updates in relation to the other items as well. Apologies, I forgot to put the microphone on. So just to say that the work on the community bed review is progressing. There is a delay to that because of the prioritisation around our budget savings approaches. So we'll bring further update on that in due course. And we've got updates on the other items, including in the action log.
Thank you very much. Are there any questions related to the action log? None? Okay, and I should have mentioned, and we'll do it for Gail's benefit, if you're in the room, to make sure you press the microphone when you're speaking, just so that everybody online can hear. And with that, I am going to pass to Gail for the Chief Officer report.
Thank you. So I'm pleased to present the Chief Officer report today. The Chief Officer report consists of a summary of some of the work that's been happening locally, regionally and nationally. So I'm just going to highlight a couple of areas in the report for colleagues. So the senior leadership structure review is progressing, and we've now slotted 2 of our heads of service. So Martin Tom will move into the head of specialist services from the beginning of January, and Maria Kears continues as Chief Finance Officer with the enhanced responsibilities that now sit with that post as of January. The remaining 2 heads of service posts are currently going through a recruitment process, and final interviews are taking place next week. The leads roles have been developed and are going through the evaluation process. So at the moment, we're still on track for hopefully people to be slotted and matched into those roles before the end of the year. And then any remaining vacant posts within the leads post will be advertised in the usual manner. The annual accounts, the IJB Audit Committee approved the audited annual accounts at their meeting on the 15th of November. And a copy of the approved annual accounts is attached to Appendix 1 of the report. In terms of delayed discharges, a continued focus is placed on delayed discharges, and this continues. There has been significant positive impact in terms of the various improvements that have been put in place. So between May and the end of October, Falkirk's position improved by around about 33%, so that's a significant improvement. However, what I would say, there has been a deterioration since that, which is related to the grip and control measures that we have put in place around our financial position. We do have mitigations that are in place, including the block-funded interim beds that were approved in IJB in September, and we'll see people going into those beds from next week. And we're commencing a test of change around discharge to assess, which will commence in 2 weeks' time. So both of those activities should have a positive impact, but a huge amount of work continues to be focused on delayed discharges. In terms of regional updates, NHS Forth Valley has formally changed its level in escalation. So it went into stage 4 of the NHS Scotland Performance Escalation Framework in November 2022. And as of the 1st of October 24, NHS Forth Valley has moved on to stage 3 of the support and intervention framework. So that's significant progress, and that really is down to considerable work across the whole system in terms of our leadership, governance and performance. There is still a continued focus on that, recognising that there's still further work to be done. A winter plan has been developed and submitted, and that includes a range of different actions around our whole system urgent and unscheduled care planning. And work has been ongoing to develop Forth Valley's mental health and wellbeing strategic commissioning plans. There's a progress update within the Chief Officer's report, and we would anticipate a further report coming in due course. The approach has taken a population health approach to develop the plan, and a strategic needs assessment has been undertaken. So I'm not going to go through the rest, but happy to take any questions or comments.
Thank you very much, Gail, and I think the work in relation to the structure progression, and I think developing the structure that for the future and for what we hope to do, I think is really important. Obviously, I'm aware it's a lot of work for many people in the team, so thank you very much for that. I'd like to thank the Chair of the Audit Committee and members of the committee for the work on the audited accounts, and to Marie and her team. And I would briefly like to open up the opportunity if there's any particular comments either would like to make in relation to the accounts. You don't need to, but we'll give the option if you'd like to.
Yeah, I suppose just to reiterate the thanks that Fiona's set out there for the team who were involved in the annual accounts process. Those were largely completed before I arrived, so some of that thanks goes to people who are no longer here and still within the Council and NHS finance team, so just like to add that. And just to say as well that the audit process was run fairly smoothly, and I was really pleased with the outcome of the report as well.
Thank you, Gordon.
Yeah, just all I would add, Chair, is that the accounts set out the financial position that we're in very clearly, and we all know that's not a good position. But what was good was that the accounts process was an entirely clean one. There were no issues thrown up, so that's always what I look for first.
Thank you very much, Gordon. I'll open up to questions, and I've got Carol Ann first.
Hi everybody. I just wanted to say thank you so much to Caroline and her team for all the work around the hospital discharges. The work that's been done so far is being received really gratefully by carers and the carer centre.
Thank you very much, Caroline. Are there any other questions or comments? Anne.
Thank you, Convener. Just like to hear a bit more about the delayed discharge position. Clearly, the financial situation for the board is rather worrying, and I just want kind of assurances that the actions likely to be taken, what impact is that likely to have on the delayed discharge position, and what mitigations are being put in place to ensure it doesn't impact detrimentally.
So I'll maybe start off and then invite Caroline in if there's any more information that Caroline would want to add. So, there has been a huge amount of work undertaken by the team, looking at systems, processes, recognising the interrelatedness across the whole system in terms of delayed discharges. The people who are delayed in their discharge from hospital, every number is a person. I think that's really important to recognise what causes that and what supports improvement in that. Covers the whole system. So that covers what we're doing in the partnership in communities, what people do to keep themselves well at home, and also what happens in the hospital when somebody comes into the front door and then goes into downstream wards. So that working together as a whole system is really, really important in this. So there has been and there continues to be a huge focus and a huge amount of work. Nationally, this is an area of significant focus as well. So the Cabinet Secretary has a meeting every single week with all the chief officers to look at performance, to support the sharing of good practice and challenges, to help us all work collaboratively together to improve outcomes for people. So there has been a significant improvement. The measures that we've put in place, so there's a number of different factors that have impacted on our increasing numbers of people who are delayed in their discharge over the last couple of weeks. That includes the measures we've put in place around grip and control around our budgets. So in terms of the 2-for-1 in relation to long-term care, in terms of we're asking managers to manage the available budgets they have around care at home. So there's a limit each week in terms of care at home. And in addition to that, obviously, this time of year, we're starting to see increases in pressures in the hospital, and there's a direct correlation between the numbers of people attending at the front door of the hospital and a lag into the number of people who are delayed in their discharges. I think that there's been significant work ongoing throughout the whole hospital to make sure that we're involved and we become aware of people at the earliest possible opportunity where they might need a little bit of help to go home. The work around reducing the unfunded contingency beds has had a significant impact in terms of the overall people, and it's about people being in the right place at the right time for their care needs. So the mitigations we're putting in place, so the IJB agreed in September around the purchase of block purchase of 16 interim beds in one of our provider care homes. So they will come on board next week, and that doesn't mean to say we can move 16 people at once. We need to do that in a managed way to provide to ensure safe and effective care. The assessment at home test of change, I'm going to ask Caroline to talk more about, because that's Caroline's been designing that, and it's based on what's worked well elsewhere as well. So there is some evidence that this will have an impact. So I'll pass it to yourself, Caroline.
Thanks, Gail. So in terms of the rapid assessment of home discharge to assess at home, that's really a test of change where we're going to provide up to 24-hour care for up to 21 days. And provide intense rehab at home, because we recognise that the longer someone's in hospital, the more chance that they're going to decondition. And actually the impact on their outcomes are quite significant the longer they're in hospital. So obviously there's clear criteria around that. Someone has to be medically fit to leave the hospital. But what we're keen to do is put in that 24-hour support for up to 21 days, have that dynamic assessment. That'll be supported by allied health professionals going in and providing that rehab. And then you've got the care element going in as well. What it's told us from other areas is there's actually been around a 60% change in trajectory for adults that have went through that process. So that's been a decrease in the 24-hour care home placements. So while we're putting this investment in at the start, we think that further down in the whole, taking a whole system approach actually, that will have a greater impact on the budgets but also outcomes for the citizens of Falkirk.
Thank you, Carol. Phil? Okay, I'll just switch mine off there.
Thank you very much. Really pleased to hear about the 24-hour care at home, and I think that will make a huge difference in terms of getting people out. Look forward to hearing more about the test and how it goes. Thank you very much. Thank you, convener.
Thank you, and I'll bring Roger in.
Thanks, Chair. I just want to reiterate what Gail started off saying just for the last speech, that we need to focus on being person-centred here, because with the pressures on people, it is very easy for staff being pressurised every single moment of the day to get things like delayed discharges sorted out and to lose that. And I think actually Falkirk have been better than some of the other areas around us in keeping that focus on being person-centred. But I think we all need to be really focused that should come before meeting targets. And if we're not careful, meeting targets becomes our priority rather than the meeting the needs of the person.
Thank you very much, Roger. Are there any other questions on the Chief Officer report? No, in that case, our recommendation was to consider and comment, and we've done that, so thank you very much, Gail. I'll move us on to our next report, which is the 24-25 budget monitoring report for Q2, and that's Marie.
Thank you, Chair. Excuse me at the moment, I've got a bit of a cough, so I've got my water here. Agenda item 6 is the Q2 budget monitoring report for the partnership, setting out the forecast as at the end of September. The net projected overspend on integrated services is 8.559 million. The projected overspend on council services as at the date set out is an overspend of 8.769 million, with services within the health side of the partnership projected to underspend by 210,000. The set-aside budgets in relation to large hospital services are projected to overspend by 7.069 million. It is assumed, as in previous years, that this position will be managed by NHS Forth Valley. The projection has increased since Q1 by 2.6 million. As I updated at the last IJB, this increase was anticipated based on the activity data which was emerging to the end of September in relation to increase in care at home packages and delivery of agreed in-year savings. This accounted for approximately 2 million of the movement, with additional items contributing to the additional movement as set out in the report. The figures presented assume the success of the budget recovery plan measures agreed by the IJB in September at this stage, as the agreement of the plan aligns with the date of the figures presented in today's report. Appendix 5 sets out the current reserves position, including the assumption that the projected overspend, excluding the budget recovery specific measures, will be managed via a draw in available reserves. The table at 4.5 sets out the expected balances with an anticipated year-end reserve balance at this stage of 6.1 million, with 3.1 million of this balance already committed on specific spend for future years. For information, the required contingency reserve balance for the IJB is 0.75% of the budget, which equates to approximately 2.2 million. At 4.4 is reference to the budget strategy agreed by the IJB at its September meeting, which included a review of all reserves held, including partnership funds. In view of the current financial position, a decision has been taken by the Chief Officer and Senior Management Team to pause any further partnership funding decisions at this time. This decision has been communicated to our third and voluntary sector partners accordingly. The variance analysis for the social care overspend is set out in Appendix 2 and at sections 5.1 through to 5.13 and sets out the main reasons for the overspend. I'll highlight the most significant ones as follows. External care at home services are projected to overspend by 8.9 million following the release at Q1 of service pressure reserves of 881,000. Built into this projection is an assumed saving of 632,000 in relation to work of the focused review team. The targeted saving in this area will be underachieved, but this work stream is expected to achieve notable savings moving forward. Offsetting this projected overspend, the in-house care at home service is currently projected to underspend by 3.8 million due to the number of vacancies within the service pending the care at home redesign work. The in-house residential care service is anticipated to overspend by 1.47 million in relation to staffing structures and the use of agency to ensure safe staffing levels are in place within the units. External residential care is projected to overspend by 2.2 million following the release of service pressure reserves held for this purpose. This position assumes that a saving of £425,000 will be achieved this financial year from the 2-for-1 admissions approach introduced to reduce the spend for the remainder of the year. An increased projected spend of £238,000 in this area is also recorded in relation to residential care for an unfunded uplift to the National Care Home Contract nursing rate, which is required to be backdated to April and passed to care home providers. Housing with Care is also projected to overspend by £440,000 in relation to staffing requirements and use of agency staff. There are a large number of vacancies throughout all services, with underspends offsetting the overall projected overspend, with the most material in assessment and care planning at £616,000. A number of savings remain unallocated this financial year to the tune of £785,000 as they are considered unachievable, the most significant of which is £576,000 in relation to reduced agency staff in residential care, which is being addressed via the ongoing budget process. The overspend of £7.069 million against the set-aside budget for large hospital services relates to a large portion of this overspend is related to unfunded contingency beds, along with the more expensive agency use in relation to vacancies, recruitment difficulties and absence throughout the services. Beginning at 5.15 and shown in Appendix 3, community healthcare has a projected overall underspend of £2.7 million. This relates mainly to underspends on employee costs throughout services and an underspend of £1.4 million against remaining development funds held related to the previous closure of Falkirk Community Hospital wards. The underspend in this area is offset by an underlying overspend of almost £500,000 in relation to complex care packages. At 5.20, a projected overspend of £2.5 million against primary care prescribing is currently anticipated. The forecast is based on the latest data available, with some focus work planned in relation to the analysis of prescribing costs. It should be noted that this position has benefited from a one-off contribution from reserves this financial year of £3.5 million, without which the forecast would be around £6 million of an overspend. At Section 6 and in Appendix 4, the projected position with regard to this year's agreed savings is set out. Savings on the integrated budget of £12.2 million were agreed this year, and it is currently anticipated that £3.4 million will be unachievable. This assumption is built into the overall position reported. A number of measures implemented to facilitate achievement of the agreed efficiencies this year are set out at Section 6.2 and include, as examples, focused reviews of existing packages, implementation of resource allocation panels, and a risk-based approach to long-term care admissions, as already mentioned today. At the September meeting, a budget recovery plan was agreed, which included the measures set out at the table, as shown in 7.1 in the report. This included the use of one-off reserves of £3.7 million. As the projected overspend has increased, it is currently assumed that the additional spend will also be required to be drawn from one-off reserves, bringing the expected draw at the year-end to £6.3 million. There are a number of risks set out in Section 7 in the report, including continued demand for care and support at home and long-term care. Budget recovery measures are likely to create some system pressure in these areas, as already discussed this morning. Also noted are the outstanding job evaluations for care staff, the volatility of prescribing costs and volumes, and the continued use of one-off reserves. There continues to be a significant challenge in managing the in-year financial position. A number of communications have been issued and engagement sessions have been or will be held with all stakeholders, including providers of care at home and long-term care, third and voluntary sector partners, council elected members, Council Financial Strategy Group, NHS board members and HSCP staff. The IJB are asked to note the current projected position, note the pause on the decisions in relation to partnership funds, and to authorise the Chief Officer to issue the revised directions. I'm happy to take any questions on the report. Thank you.
Thank you very much, Marie. I think obviously it remains a concerning picture, even with the ongoing recovery actions and savings. And I know across a number of the overspend, the use of agency staffing, but it has that use of agency staffing to augment vacancies as a challenge across the NHS as well. So I think we're seeing that picture being reflected in our partners too. I suppose I have just one point, and I note that we've got the decision around pause and partnership funding. I wonder if you can say a little bit more about that, but I will note that there is further discussion on that in the next paper, but I think it might be useful just to expand upon that a little bit.
I suppose first on your comments around agency, Chair, there has been significant work done in NHS Forth Valley around reducing nursing agency work, nursing agency use, and that's almost dropped to zero, although that's offset by some potential bank and potential overtime work, but there has been significant progress in that. We've also got additional measures within the partnership around agency spend, where senior staff have to authorise all agency spend, just to make sure that we're keeping a close eye on that as well. In relation to partnership funds, in view of the current financial projections and the required use of one-off reserves, it was thought that this would be the most sensible decision at this point in time. We will be expected to exhaust all of our other reserves prior to coming below an expected contingency reserve position. So at the moment, that pause means that any uncommitted non-recurring reserves for partnership funds will not be used up. So this is in relation to uncommitted reserves at this point. So that's why that decision has been made, to protect those reserves in view of the current overspend position. A full review is going on at the moment of the overall financial position for partnership funds, and I'll talk about that in the next paper as well, and we'll bring back that full position in January.
Okay, thank you. I'm going to open up for any questions or comments. So I've got Anne and then Gordon.
Thank you, Convener. I think we're all well aware of the dire situation that the budget's in, and I think you deserve a medal for the work that you're doing here on that. So thank you for that. I wonder if we could maybe say a little bit more, particularly about the 2-for-1 approach and the impact that may have on people not coming out of hospital as early as you might have wanted them to, and what are the ways in which we're trying to mitigate against that?
Yeah, so I suppose I might bring in Caroline around
Sure.
that one. So obviously we've implemented that around a financial position, and that's a risk-based approach that's being taken, but Caroline will probably speak a wee bit more about that. Thanks.
Thanks. So in terms of the mitigations, we've obviously got the interim block contract. That will offset and help the flow in terms of the system. So that allows us 16 beds. The previous outlined test of change as well will also target that cohort that would have previously went into 24-hour care. So you've got the mitigations in terms of actually managing the risk around the 2-for-1 approach. What we're doing is we're monitoring that on a weekly basis. In terms of the risk-based approach, if there's a situation either in the community or hospital that requires an urgent admission, then we will facilitate that, so that we're managing the kind of crisis situations and not allowing anyone to be at risk of harm. But we do recognise that it is slowing up the system and will have an impact on delayed discharge.
Okay, thank you. And just one other issue. I mean, I've now been on the IJB for 2.5 years, and for the entire 2.5 years, every financial report comments on the issue of prescribing and the problems of the cost that and the overspends there. I'm not sure who's the right person for this one, but if you could say a wee bit more about what's happening to tackle that problem, because we're not the only IJB with this problem, and it really is something that needs to be taken head on.
Through yourself, Chair. Thank you very much. Excuse me for the question, Councillor. It would be fair to say, and I'm sure everybody in this room knows, that there are many, many moving parts in relation to the prescribing world. You've got everything from the volatility of international markets and new medications that come along that are branded, and at that stage you're still paying for all the development costs and the profits for the organisations that have made them, etc. And then you try to move over to the generic, etc. And the generics are now going up in price, and therefore the differential you used to experience is different than it once was. So that a myriad of those external elements that are then impinge upon, there is there is, you might be surprised to hear, a lot of work going in relation to medicines optimisation and medicine management and governance. And I have to say, within Forth Valley, there is a lot of activity around about that, taking into account the extreme pressures that the system is under in terms of the medication costs, prescribing costs, etc., going up. In fact, Marie and I were yesterday at the Medicines Optimisation Board, and they were identifying, potential savings over the next year that were quite significant and running into to 7 figures. And it would be wonderful if we were able to achieve that against the pressures and against the trends. One of the challenges that we debated long and hard yesterday is that up to now there has tended to be quite a systemic approach to trying to address the issues. And if I characterise that as we tell you all the medicines you should be using, we try to use the most efficient systems, we try to get things to change, and we do all of those things. We can't understand why everybody doesn't just change it. And I suppose what myself and Maria were trying to introduce is that we need to ally this systemic approach with a behaviourist approach as well. And whether that behaviourist approach is purely on the basis of us imposing ourselves a lot more at the prescribing end, but also the public awareness end, or in some respects a combination of that and incentivisation schemes to try to get behaviours to change, because that seems to be the crutch at the ground level, if you like, in relation to all of the activity going on to trying to manage the escalating costs and actually the realities of that happening on the ground. So what we're trying to do is to look at a programme that would include schemes of trying to assist prescribers. And when I say prescribers, yes, the vast majority are coming through primary care and coming through your GPs, etc. But a large number of prescribing instances are also in secondary care and acute care. And sometimes one affects the other. So a decision made in a hospital or in a secondary setting can then be quite difficult to unpack when it comes to the pressures in primary care and how long you get with your GP, etc. So we're trying to look at this. How do we support frontline practitioners to be able to make decisions that they themselves are not exposed with? And again, to illustrate that, if you're a GP and you get a very limited time with somebody who's been getting the same prescription for a long time, it doesn't matter whether you believe they really shouldn't be getting it anymore, because it's actually not really doing them a great deal of good. And there's loads of instances of that, very costly instances of that. They want that, and you have a limited time to debate that with them. And it then seems that it's you that's making that decision to then restrict their access to something or try to change their medications. So what we're trying to do is find a way of trying to support that decision making so that they're not as exposed. There's also the issue, and I realise I'm going on and on and on here. But there's also the issue of the public's awareness. There has been, I'll be careful what I say here, there has been a kind of sense of nervousness about hard-hitting campaigns in the area. It would be fair to say. But others have done it, and others have done it quite successfully and with an impact. And to illustrate that, I think it was East Ayrshire. Sorry, I'm trying to remember. Was it one of the Ayrshires? What Ayrshire was it? But one of the councils really far over in the west have just undergone a very hard-hitting campaign that doesn't just nag people in the sense of saying, don't waste your drugs, don't get too many, that kind of thing. Don't ask for things you don't really need. It relays it in real terms in relation to the cost that is being deferred by the use of the overprescribing, etc., and people stocking things with how many nurses that could be, how many other things that could be, the impact on services. They've run a very successful campaign in relation to that. Aberdeenshire have done something quite similar, maybe not quite as hard-hitting, and trying to get us into the space in which we see the combination of the systemic approach, which I do think will yield dividends if the behaviourist element is also successful. And that's the combination I'm trying to do. So I'm sorry that at the moment it doesn't feel as if we're making inroads into the deficit. I think the deficit would be much worse if work was not going on in the background, but that's no consolation sitting here right now. It's about taking these things to the next level. And I want to say more about that at another time in which there'll be more chance to have this opportunity, I believe, in January. Sorry, that was very long-winded. That's probably more than you were.
It was not. I appreciate that you've given us a lot of detail, which I think was very valuable and reassuring in terms of the activities that are going on. Without wanting to drag this out, I would also just ask, when you're coming back to talk about it a little more, it might be worthwhile talking a little more about social prescribing as well, because there are a number of issues about, rather than simply prescribing a pill, prescribing activities that might actually be better in a lot of ways.
I'll very, very briefly come back on in that. And in some respects, I kind of touched on it in that space in which what happens with the GP at the front line in terms of the time with the person. And there's a combination there of how do we support them to convince people there is an alternative to a prescription pad, but how do we also make sure that there are robust things in place that that doctor can feel confident about? It's all very well for them to think, actually, you don't really need antidepressants. This connection to something would be better for you. This activity would be better for you. If the doctor in that room doesn't know whether that's still there, how the person will go to it. Will they go to it? Will they stay connected to it? It's about finding ways of aligning their current resources around about link workers, etc., in order to support people to pursue and stay with alternatives to prescribing. So again, you're absolutely right, and that's something we'd want to talk quite a bit about, if that's okay. I will stop now.
I won't take it any further, but thank you very much for your full and detailed response. Thank you, Convener.
Yes, I would agree. It's very helpful, and I think I look forward to the deeper discussion moving forward. I'm going to bring in Gordon now.
Thanks, Chair. Firstly, thanks for the report, Marie. It's very clear and sets out in forensic detail exactly how bad things are, I guess. But it's good that we do have that full position. There were two issues I was going to raise. One was prescribing, so I think we've probably said enough on that. I won't prolong that one. The other one was around the reserves position, and you and I had a kind of offline conversation, because I was worried we were getting near the point where we'd be breaching our own reserves policy. We're not at that stage. It's good to note, but we are in the position, I guess, like a lot of IJBs, where we had reserves, which has cushioned some of the overspends over a few years. We're now reaching the point where we can't keep doing that forever. It will run out, and that leaves us in a very difficult position. But I think the paper sets out some really difficult decisions that have been taken, and I would endorse the logic of having to take those decisions, which I'm sure nobody wanted to take. But I think they are the sensible ones to. In relation to the partnership fund, it's not about cutting grants that have already been made, as we've seen other IJBs doing or attempting to do in recent times. It's about the uncommitted money, so I would support the recommendations. I think it's a realistic approach to where we are right now.
Thank you, Gordon. I'm going to check if there are any more questions or comments. Okay, in that case, we've got two recommendations which are about noting. And the final recommendation is just to authorise the Chief Officer to issue revised directions.
Agreed.
Thank you. So moving swiftly on to agenda item 7, which is the business case, and that's Marie again.
Thank you, Chair. Agenda item 7 sets out the draft business case and medium-term financial plan from 25-26 through to 27-28. The IJB agreed their budget strategy at a September meeting, which set out the process and timeline for agreeing the 25-26 IJB budget and the medium-term financial gap. A key stage in the timeline will be the Scottish Government budget settlement expected on the 4th of December. The commitment to the Scottish living wage for adult social care workers and any associated uplift is expected to be funded and passported via Falkirk Council, and that position is set out. The position is set out in the paper assumes this. The Budget Working Group are working to identify savings proposals and transformational change proposals to bridge the medium-term financial gap. Following today's meeting, this draft business case will be remitted to our partners and will be presented to both Falkirk Council and NHS Forth Valley Board meetings. It is anticipated that final funding will be confirmed by both the Council and NHS Forth Valley in February 2025. Indicative funding is assumed to develop the IGB budget until such times as final settlements are available. The reserves position discussed as part of the Q2 report is also set out in the draft business case at 3.5 for information. The budget gap reported in the budget strategy paper in September indicated a medium-term financial gap of 18.9 million, set out at 4.2 in the table, including additional pressures in 25-26 to address previous non-recurring funding and additional care and support at home pressures, with later year adjustments to assume payroll management assumptions. The assumptions within the overall medium-term financial plan are set out at 4.3 and include most significantly pay uplifts for council and health employees, with only the NHS agenda for change uplift expected to be funded at this stage, demographic pressures of 800,000, a 5% uplift for prescribing and other items as set out within 4.3. Within the 24-25 financial position, as we've just heard, a number of other pressures are emerging and require to be incorporated into the financial plan as follows. Pressure in relation to in-house residential services. Although it is expected that proposals would be brought forward in relation to these services, an implementation period should be anticipated. Therefore, a temporary pressure of 1 million has been added, which can be removed once any measures are approved and implemented in relation to in-house residential services. An efficiency of 569,000 was agreed as part of the 24-25 business case, which is unachievable, therefore must be removed from the underlying budget. Prescribing pressures continue to grow, and current recommendations are that we should include a pressure of 10% overall, which is unfunded. The current medium-term financial plan includes a 5% uplift of 1.7 million. I have included an additional 700,000 at this stage, which will equate to addressing the current predicted overspend in this area. It is also hoped that associated savings will be brought forward for prescribing as part of the budget process. Once added to the previously notified gap, the revised overall gap is shown in the table at 4.11, with an updated figure of 21.164 million over the next 3 years, with 13.9 million related to next financial year. Some initial savings have been identified by the Budget Working Group or are already agreed and are set out in the table at 5.1, totalling 1.160 million. The Budget Working Group continue to identify and work through proposals to close the financial gap, and the timeline is set out again for the IJB at 5.3. An IJB budget development session will be held on the 6th of December with initial proposals to be issued prior to that meeting for information. The draft business case will be remitted to our partners for their meetings in December, and a period of public consultation is being planned to begin early January with work underway on the planning of this process. Section 6 sets out a proposed approach to the agreement of partnership funds for next financial year. A 3-year partnership funds investment plan was agreed by the IJB in March 2024. However, in view of the current financial position, the budget strategy paper set out that a review of all recurring and non-recurring reserve spend would require to be carried out, including partnership funds. It is proposed that a review exercise is carried out with a co-design approach for current third and voluntary sector partners as set out in Appendix 1 to the report. Current recipients will be invited to bid for funds next financial year, with final agreement of allocations to come to the IJB in March. The review will seek to consider the extent to which current spend within NHS, Council and HSCP budget lines should continue to be funded via partnership funds held, and also to reduce reliance on non-recurring reserves and also arrive at a reduced recurring funding allocation. A proposed change to the funding package will be presented to the IJB in January for approval, following consideration of the emerging overall budget position and updated financial projections at that time. Communications will continue to be issued to our third and voluntary sector partners, and our third sector interface, CVS Falkirk and District, have helpfully offered to support organisations to provide capacity building and funding support to those organisations who may be affected. I'm asking IJB to approve the proposed approach set out in Appendix 1 today, Appendix 1 to the report. Our partners' financial positions continue to be challenging, with Falkirk Council reporting a medium-term financial gap of 56.4 million. NHS Forth Valley have a current year projected overspend of approximately 40 million and will produce a 3-year financial plan, which is also expected to be extremely challenging. Additional risks set out in Section 8 include care at home demand, long-term care placements, national care home contract negotiations, which have been difficult over the past few years, pay awards over and above assumed levels, the employer's NI implications, which we are currently don't expect to be fully funded, agenda for change non-pay elements, prescribing levels and pressures, as already discussed this morning as well, the outstanding job evaluation for care workers, and the implications of the National Care Service, although which is paused for the moment. In conclusion, the updated medium-term financial plan over the next 3 years, the gap is 21.164 million, with 1.160 of savings included in this paper, bringing the overall gap to 20.004 million, with 13.047 million for next financial year. The challenge set out is significant, and it is imperative that recurring deliverable solutions are brought forward and agreed. A package of potential savings and transformation options will be proposed in due course to be shared with the IJB at the future development sessions mentioned and issued for public consultation in January. Further development sessions will be held as the process progresses, with final budget proposals to be brought in March 2025. Communications with stakeholders will continue over the coming months, with in-person engagement sessions being planned as part of the consultation process. I'm happy to take any questions on the report. Thanks.
Thank you very much, Marie, and obviously this is a report that continues the difficult news. I'll hold back on asking any questions around the partnership funding because I'm sure the others will have questions or comments. But I'd like to ask around the implications of the employer's national insurance rise. Now, I know that there are indications that there will be or is funding around the local authority and the NHS, although we don't know quite what the balance is of that at the moment. But I'm specifically thinking around the implications for the National Care Home contract and our third and independent providers and GPs, because I did read a letter from CVO that they had written in regard to the fact that there were a number of providers and whether we're in the public independent or voluntary sector is all providers, and obviously the National Care Home contract is one that there's a very specific, almost like a parameters within that. But I wonder if there's any work going on nationally around the implications of that, not just for our IJB, but also for the wider system and the wider system across Scotland.
Yeah, so obviously I've set that out as a risk in the paper. Although we are expecting funding to be available for partnership, staffing, employers' NI implications, the budget settlement from UK government makes assumptions around the level of staffing and the level of pay. Now in Scotland that tends to be a bit higher, so what that means is when those consequentials come through, the assumption that UK government make around the employer's NI often doesn't cover what that means for Scotland. Now, we don't know the definitive answer to that at the moment. We won't know until the settlement's announced. And I'm having discussions with Amanda Templeman around that. But the expected amount for the partnership is around 400,000, but we don't know that will be fully funded at this stage. So I haven't included a figure around that. So once we know the full implications, we would need to do that for our own staff. Absolutely, those negotiations around provider uplifts. So Scottish Government would pass on the implications for the Scottish living wage, and I would hope that would include an element of employers' NI, but again, that's not clear at this stage at the moment. And yes, that will have implications for GPs through the NHS funding. It will have implications for our providers and our third and voluntary sector providers as well. But at this stage, that it's unclear how much we're going to get for that. Around National Care Home contract, obviously the negotiations around that have become more difficult over recent years, with it becoming more difficult to get an overall agreement. Although we've managed to do that, there's always the risk that we would end up not having a national agreement around national care home contract, which would mean us negotiating individually with local providers. But indications at the moment are that the national care home contract level may be slightly more than the Scottish living wage level. Again, I'm sorry to keep saying it's not clear yet, but actually it's unclear at this stage. So I will update the projection. So when I come back in January, the latest position will be included in whatever paper we bring in January. The CFO network absolutely are meeting with Scottish Government and COSLA regularly around this and appealing around the employer's NI position for all providers. But as I say, it will become clear once the settlements are available what's going to be covered.
Yes, obviously we have the Scottish budget in double quick time, so hopefully that will clear the picture a little bit, if not completely. I'm going to open it up for any further questions. Ian.
Thank you, Chair. Just a quick comment on the national insurance. First of all, we worked it out in our own organisation, and it's about 2.6% of the salary bill. So it doesn't sound a lot, but it's quite significant. And I think that could have an impact not just in partnership, but those other organisations and GP surgeries. What I'd like to say on the partnership fund scenario is it is a very challenging situation for all concerned, but I've certainly appreciated the engagement and communication from officers within the partnership to keep communication lines clear and try and have a pragmatic approach to, I think the last we spoke about is try and do it in such a way as to do the least harm possible and ensure that the most important services that are available in the community can continue to be delivered in a difficult situation.
Okay. Thank you. And following on from Ian's point, I think it's just asking for it to be noted that we really are extremely concerned about the potential impact on the third sector. We know that there are difficult decisions to be made. However, last year's review was thorough, and that 3-year investment plan, there was a real level of confidence and trust cross-sector. And also many of these organisations do have 3-year joint working agreements. So this is not about project funding where organisations are expecting to have to seek other funding within the matter of months. So the pausing of all the funds is really of significant worry. However, as Ian has alluded, we have been speaking with Marie and Gail and trying to find a positive way, or positive pathway through this review. This review will need to happen within a matter of days and weeks, not like last year's review that lasted 9 months. And so you can imagine the tension within the third sector as well, and especially given the earlier conversations regarding community-led support and social prescribing, we can't have one without the other. So it's really just to say that we are both, Ian and myself, are very committed to trying to figure out how to make this review positive. I obviously understand the pressures because my organisation too, the funding is under review, but our commitment is to try and support all of the other 30 plus organisations that this will affect. Because unfortunately there are no other funding streams that we can turn around to help these organisations within a matter of weeks. A standard funding application can take anything from 6 to 12 months. So it's just to have that noted that, yeah, I think I'll stop there. Thank you.
Thank you, and thank you for the comments, and I think they're well made, and I very much recognise the very short timescales in terms of that alternative funding. So I don't know if Marie or Gail would like to come in at this point.
Okay, yeah, thank you, Chair, and thank you, Ian and Victoria. And so it is obviously across the board, it's a really, really challenging picture, and we're trying to navigate through this in a way that does support the people that need the support in our communities, because that's the most important thing. So there are difficult decisions, there will continue to be difficult decisions. what our commitment is about being open and transparent and working with people to navigate through that. And I think from myself, I just want to say thank you to Ian and Victoria for all your input and support so far, and that commitment to continue to provide that input and support is really appreciated, because there isn't an easy solution in this, but we want to take an approach that is open and transparent and participative and leads to the best possible opportunity for getting the least worst decisions to support people as best we can.
Thank you, Gail. And Roger.
Thanks, Chair. Just in relation to section 8.2, I mean, obviously the overspend recently in care at home is something that clearly needs to be looked at carefully, but it concerns me that maybe you end up, if you're looking at week to week, there have been weeks where delayed discharges will things like that to prevent delayed discharges. The care at home requests by social workers and assessors is going to be overwhelming. So is this restriction going to have knock-on effects on other parts of the service? Because I know my colleagues who are feeling that every single request for care at home is about either preventing serious harm to somebody or getting somebody out of the hospital.
So I suppose, yeah, obviously 8.2, what it's setting out there is that limit on the number of care package hours that's being put in place. I think inevitably it will have a bit of an impact on the system. There's no doubt about that. Caroline, we have resource allocation panels in place now, and also there's that risk-based approach being taken around those limits and how we're managing that. We're looking to spread it equally over teams so that we're taking a pragmatic approach to how that's managed. I think Caroline will probably come in and talk about the processes that we're going through to manage that position as well.
Thank you. Just in terms of how the approach we've taken, in terms of deciding what the level of allocation is, what we did was we looked back at the data for the last 12 weeks, so we could work out like what level of provision normally that we could provide to each team, what available resource there was to be able to support care at home. What I would say is in terms of monitoring, in line with the 2-for-1 care at home admissions, we're also monitoring the care at home hours very closely, and that's not just about the level of spend, but it's also about how is that impacting on the system, how is it impacting on the adults that are awaiting a resource, where are they waiting, how is the risk being managed, and at the same time really supporting the teams around it as well, because we recognise that this is quite a difficult thing to do. So there's something about resilience and wellbeing, and that's very much the approach we're taking. So one of the things that we're doing is building in a kind of development session, not just about the budget, but also as a team managers, frontline team managers, how are you feeling? How can we support you? So it's very much a process that it's quite iterative, but we recognise that we're really at the early stages of this, and we'll need to refine it as we go through.
Thanks. Could I just say that I think that frontline staff at the moment are not feeling very supported about this, and maybe they just need a bit more communication.
Thank you, Roger and Caroline. And
thank you, convener. Just in terms of this, I mean, a number of the things that have been questions that have been raised in discussions there, I just want to make a plea really. Remember that what it is easy to cut is the preventative services, and yet those are the services that in the longer term avoid further costs, not to mention the distress and difficulties that it creates for the individuals concerned. So I think in all I recognise that the crisis of the financial crisis that the IJB is in, but in all the discussions, I think it's important to remember and not forget that we need to look at the preventative measures and the long-term impact of reducing our support for prevention.
Thank you, Anne, and I think Tom made that point very clearly around the prescribing and that wider supports and different alternatives as well. So I'm going to. Are there any further questions or comments? Margot.
It's really just a comment. Just concern for service users with the possible 8.2, the restriction on the number of hours per week, and the risk-based approach to be undertaken. This is of concern, and I'm just wondering, can we involve service users more in explaining and involving them in all these measures to meet the additional pressures?
Thank you, Margaret. I wonder, Caroline, if you're able to talk a little bit about some of the engagement and potentially what work might be possible.
So I guess on a case-to-case basis, we're certainly having like dialogue with people that, you know, are perhaps in the position of waiting for a resource to become available and explaining the current context. And part of what we're doing is we've obviously got a dynamic risk assessment in terms of the situation, so that if we need to provide a resource quicker, then that's what we're doing. In terms of the wider process, one of the things that we're doing is reviewing our eligibility criteria, and that's got a short life working group that's got representation from, you know, carer centre, advocacy, and also SDS Forth Valley, so that we can look at from a kind of person-centred point of view, how can we make clearer our application of the eligibility criteria, and with that, what is the communication strategy? And we're going to link in with the consultation period that's going to take place in January around what that criteria looks like, so that we're really getting feedback from as wide an audience as possible around how we shape, how we deliver services. So I don't know if there's any other information that'd be helpful around that.
Yeah, sorry, it was just to say, as part of that, the budget consultation in January that Caroline mentioned, we are actually going to be contacting service user groups and carer groups and I'm happy to go along to some of those forums as well, because we're aware that an online consultation maybe doesn't reach everybody, so we're really keen to engage with people as much as possible around some of the measures that are going to be coming forward. We know they're very difficult, but we're really keen to gain everybody's opinion on that. So if there are any groups or any service user groups that you think might want to be involved in that we might not be aware of, please let us know. But our communications engagement staff are working on that with us at the moment.
Thank
you, Convener. Just, I think the communication issue has been quite high on the list here, and I think first and foremost, staff and our partners need to have those communications, and as well as service users, because it's the staff and partners who will often be passing on to service users. But I just wanted to say I have welcomed a much more open approach. Marie and Gail have both been meeting with a number of us to ensure that we understand the details, and I'm aware that I don't know how she finds the time to go around the many different organisations and groups that Marie has been meeting with. So I want to just put that on the record to say how well Marie and Gail are doing in that regard, to be open upfront. The messages we're getting are dire, but at least the carriers of those messages are making sure that they engage with people. So thank you.
Thank you, Anne. I'm going to. Are there any final comments or questions? Just checking online. No, in that case, we have our recommendations are 2.1 and 2.2 are noting. So 2.3 is approving the proposed approach in relation to planning expenditure against partnership funds. Okay, to agree that.
Agreed.
And the 2.4 is noting the additional funding pressures. So thank you very much, everyone, for that discussion. I know it's not an easy one, but thank you, everyone. I'm going to move us on to agenda item 8, which is the Forth Valley Palliative and End of Life Care Strategic Commissioning Plan, and I'll keep trying to say strategic easily, but I can't. And I'm going to move to Nicola Wood, who is online.
Thank you. Thanks, Chair. I also struggle with strategic, and it's throughout my presentation this morning, so bear with me. So this report presents the draft Forth Valley Strategic Commissioning Plan for Palliative and End-of-Life Care to the Board for consideration and approval. The report outlines a joint approach taken from both health and social care partnerships to develop the plan, including consultation and engagement activity. The Strategic Commissioning Plan, if approved, will form the basis of any review of current spend or proposals for future spend in relation to palliative and end-of-life care across Forth Valley. And it's worth noting that this Strategic Commissioning Plan was approved by the Clackmannanshire and Stirling IJB on the 20th of November this year. So the report highlights that palliative and end-of-life care is a national and a local priority, with an ageing population and comorbidities and complexities adding demand to an already pressured system. The evidence tells us that the over 85 population will increase by 6 to 8% by 2043, and that we'll also see a significant rise in those living with dementia. Approval was granted by the IJB in March 2024 to develop a strategic commissioning plan in relation to palliative and end-of-life care in collaboration with Clacks and Stirling to ensure consistency and sustainability across Forth Valley for palliative and end-of-life care provision. This consistency was not just in relation to the location of residence, but also to ensure that there's equitable access to services and support regardless of the type of illness that a person is dying from. The draft Strategic Commissioning Plan builds upon a previous unpublished review that took place in 2022's findings, and following consultation with staff and citizens, it ascertains what those using and delivering services believe the key areas of focus need to be moving forward in relation to palliative and end-of-life care. The plan not only takes into consideration feedback from professionals and those with lived experience, but is also cognisant of the current financial climate that's already been set out in the meeting today. You will see in the paper that one of the main performance measures is Quality Outcome Measure 10, which measures the percentage of a person's last 6 months of life that's spent in a community setting. And while there's been improvements made since 2024, there's actually been little to no movement on the figures in the last few years, and Forth Valley have never been able to meet or exceed the Scottish average or meet the 90% target that's been set. Currently, we're sitting at 88.5% of a person's last 6 months spent in a community setting. Section 5 of the report provides details on the consultation period, which includes 2 rounds of engagement sessions and 6 face-to-face group sessions seeking the views of those with lived experience, staff from primary care settings, district nursing, care at home staff, care home staff, as well as colleagues from third and voluntary sector organisations. In addition to the in-person engagement sessions, an online survey was open for 5 weeks, which was promoted widely through social media and community groups. 56 people engaged with the survey and provided their views. Those who contributed to the consultation were asked to comment on their experiences of palliative and end-of-life care, what they felt worked well when accessing or delivering the services, and what could be improved based on their experiences and what we should be aspiring to achieve moving forward. During the consultation period, a total of 264 people engaged with the process. Included in the plan is data showing that in 2023, 43% of people who died across Forth Valley actually died within an acute hospital setting. And we know that through this consultation and other work that doesn't align with several people's wishes. In addition to this, the plan also includes 6 key themes highlighted for focus moving forward, which are summarised in section 6.2. The plan also includes a projected position for that quality outcome measure 10 of 90.6%. And if that's achieved, that would save just under 11,000 bed days. So this would not only support people to spend more time within community settings as per their wishes, but would also relieve pressure on other parts of the health and care system. If approved, there will be an implementation plan developed and presented to the IJB in March 25, and next steps will include a Pan-Forth Valley Commissioning Consortium approach, which will have key representation across groups, including service users. The consortium will be asked to review current spending and consider future commissioning, and any future spending must be in line with the plan and the key themes identified. As the lead partnership in this work was Clacks & Stirling, they developed the EPIA. And I just want to provide the IJB with assurance today that this will continue to be developed and to ensure that it captures relevant information relating to all of Forth Valley residents. I would also like to make the IJB members aware that correspondence has been received from the Chief Exec of Strathcarron Hospice following submission of this paper. The Chief Executive feels that the figures reported in the plan are grossly misrepresenting the costs for the hospice, as there is a view that the paper is solely about NHS Forth Valley funding into the hospice. I am keen to confirm with the board members that the figures quoted for the bed day spend for the hospice provision are intended to represent the totality of the spend and not just that funded by NHS Forth Valley, and that all figures related to the care home and care at home provision is that funded by Clacks, Stirling and Falkirk IJBs. The Chief Exec of Strathcarron Hospice would have preferred that the paper reflected the bed cost based solely. Oh my goodness, sorry, my fridge is talking to me in the background. The Chief Exec of Strathcarron Hospice would prefer that the paper reflected the bed cost solely on allocation from NHS Forth Valley. However, both Chief Officers agreed to reflect the Chief Exec's views to the IJBs and in the minute of the meetings, but do not agree to with the request to amend the costs included in the plan. So in conclusion, the proposed strategic commissioning plan highlights key themes from the consultation period, which will be used as a direction of travel when reviewing or commissioning services relating to palliative and end-of-life care. This is a Forth Valley-wide approach which will support whole system working and aim to reduce variance to Forth Valley residents when accessing the services. So the Integration Joint Board are asked today to approve the Forth Valley Palliative and End-of-Life Care Draft Strategic Commissioning Plan. Note the next steps as proposed in section 7 based on agreement of the plan, and authorise the Chief Officer to issue the directions at appendices 3 and 4 to the Chief Execs of Falkirk Council and NHS Forth Valley. Thank you, and I'm happy to try and answer any questions you may have.
Thank you, Nicola, and a very detailed plan, and thank you for noting those comments from the Chief Executive of Strathcarron, and they'll be noted for the minute. I think I just wanted to comment on the key themes, and I think how important those are around communication, coordinated care, staff and learning and education, but also that for families and carers, but most importantly that holistic future care planning. I think it's absolutely vital. I think being able to have that person-centred plan that you with your family have put together, and I think it's a time of a lot of fear and uncertainty, but I think having the things that you can control, that you have set those out clearly, I think is so important, so that you're in control of those decisions and they're your personal decisions. Obviously, circumstances can change, but you've set out the things that are important to you. So I think that's really excellent. I want to open this up now for questions or comments. I'm going to bring in Anne first, and if there's any other comments, just put on your light or give me a wave.
Thank you, Convener. Yes, I mean, this is a very timely report, and obviously I think we are all concerned to know that there's a lot of work going on to improve the palliative and end-of-life care. It is absolutely vital and the need is growing. I'd like a little bit more information though about the actual costs, because I think that's a fundamental issue, and I'm not sure I'm fully understanding what the Chief Executive of Strathcarron is saying in terms of the figure versus the figures that are in the report. And I wonder if you could clarify that, please.
Yes, of course. I'm getting echo, sorry. I don't know if you guys are getting echo in the room as well. But so the costs within the paper are in relation to the total funding that the Strathcarron Hospice receives. So they receive £5.9 million in funding, and that is split between NHS Forth Valley and NHS Lanarkshire. So the cost per bed day is based on the number of bed days that were reported through Public Health Scotland that was spent in the hospice, and using that figure of 5.9 million. What the Chief Executive of the hospice was keen to highlight was that if you take the NHS Lanarkshire costing out or the funding out and use the NHS Forth Valley funding, then that cost per bed day figure the Chief Exec predicts would be lower than the £1,200 that's documented in the paper. But as I say, both chief officers are aware of this communication that came to both Gail and David, and they were both keen that actually it was the totality of the funding that should be represented in the paper.
I think Gail also wants to come in on that.
Yeah, just to add to what Nicola has said, so obviously the hospice do a huge amount of fundraising as well, so there's a lot of additional funding that comes in through various means to support the provision of the valuable care that the hospice does provide, which is included within that figure as well. So that's the total cost from Public Health Scotland of a bed, which doesn't articulate where the different elements of funding comes from.
We could perhaps take offline a discussion about the detail of how that breaks down. It's just an area of interest.
Thank you, Anne. Roger.
Yeah, no, just a comment really that over the 40 years of social work, I've worked with palliative care off and on, and I've always been struck by the huge difference in the skill of the specialist palliative care workers compared to most of the rest folk, particularly those at Strathcarron, and I actually look forward to working with these people because I learn so much from them, and it's a shame that, and this comes out in the report, but it's a shame that the level of skill that Strathcarron and other specialists have can't be shared more with a wider. If everybody's skill went up to that level, I think the palliative care, the skill of palliative care across the service will be so much better. So education, I think, can be really a benefit to so much of the service.
Thank you, Roger. Are there any other questions or comments? Margot.
I think it's very timely that we're discussing this as it goes through Westminster today, that the vote on assisted dying, because I think we're probably all in agreement that it's so important to increase funding to hospices because of the quality issue as well as the time issue in palliative care and the quality of life that people are given by the hospice movement. So it's really just to say it's good to have the figures and to know how much we're giving to support the work of Strathcarron Hospice, but hopefully nationally and both sides of the border that will perhaps increase, and it will be a future financial outlay that we have to take into account.
Thank you, Margaret. I think that's a point well made, particularly in the current the current environment, and I suppose probably leading back to what we discussed around things like employer national insurance and the impact across for other services as well. But I won't belabour that point. I think I've made it more than once. But I'm going to open up for any further questions, any further comments? No, in that case, are we happy to approve the plan and to authorise the Chief Officer to issue directions?
Agreed.
Thank you very much. Okay, so my agenda's under there. So our next paper is on the redesign of day services for adults with disabilities, and I know Martin's going to introduce the paper, and then I think Margaret is going to come in as well on, and also in relation to any questions. Martin.
Thank you, Chair. This report really is the culmination of some really lengthy engagement and consultation with service users and staff following the closure of Oswald Avenue and Dundas at the start of the pandemic. Members will probably recall back in 2020 there was a decision taken to close our day centres on the basis of the impact of COVID-19. Following easing of restrictions, we reopened Dundas and we opened up a community-based service. Up until that point, our services had always been really buildings-based services, very traditional day service models. But the pandemic forced us to look at alternative ways of working with people. And at that point, we established a service in the community as well. So following, I guess, the reopening of services, we have very much focused on that two-model system, the community support within across the Falkirk area and a buildings-based service at Dundas. We were really keen to get the views of service users around the model for day services within Falkirk before we took any decisions around going back to the old buildings-based model. You may recall that we've done a lot of work with iHub and Health Improvement Scotland looking at a model for day opportunities for adults with an LD and physical disabilities, and that too informed the engagement and consultation that we undertook with service users. So this report really is, I suppose, the vision for services that came out of that consultation and engagement with staff, service users and their families. The report really highlights that when we asked families around what do they want, there was real support for continuation of that community-based service model, but there was also a real recognition that we need to maintain buildings-based day services as well. When we asked staff and service users around, do you want us to reopen Oswald Avenue and go back to the service that we had before, the feedback was really clear that actually they didn't. They wanted us to continue to support people in the community, but there was a desire to have an improved building-based service. So the ask really at the end of the consultation was that we continue to provide community-based services, but we invest some additional money into the fabric of the building at Dundas, and that we increase the staff cohort within Dundas to support service users in a much more effective way. So really this report highlights the feedback from the consultation, and I asked members to agree that new model. Part of that is the allocation of some capital funding to improve the fabric of the building at Dundas, to improve the facilities, to use some of the staffing budget that has become available since the start of the pandemic. As we haven't opened Oswald Avenue, we've been able to hold some vacant posts. And we've done that on the basis that we wanted to be really clear around the model going forward. So the intention is to use some of those vacant post funds to increase the capacity of staff at Dundas. Also to actually ensure that there is permanent funding for one of our other resources. It's set out in the paper. We intend to use some of the funding to put permanent funding into the Dollar Park Dementia Service. At the moment, that's the evening and weekend workings funded on a temporary basis from partnership funds, and members are being asked to agree that we use some of the staffing funding that we've held back from Oswald Avenue to make that permanent funding. So in terms of the recommendations, members are being asked to, a second to scroll back, to approve the model of day services, as I said, that was identified through the consultation engagement. Note the proposed building adaptations for Dundas using the capital fund that we've been given by the council. Agree the closure of Oswald Avenue as a day centre resource, but actually note that we intend to take a scoping exercise to look at any potential use for the Oswald Avenue resource, and to ask the Chief Officer to instruct the council in terms of direction around pooling the two previous budgets for Dundas and Oswald together. I'm happy to take any questions. I'm joined by Margaret Tom. I have to say no relation, but Margaret manages our community mental health resources, so I thought she'd be better able to answer any specific questions about the service. Thank you.
That's great, thank you, and welcome, Margaret. I want to say thank you to all the people who use the service and their families and carers, and also the staff of the day services for their engagement and really the clarity that they've provided on what the future model should look like. And I think it's been a really positive approach with everybody involved. And I think moving on to that decision about additional investment and being able to respond to that request that there needs to be some work on the fabric of the building to make it fit for the future, as well as increasing the staffing, including for the joint dementia initiative, because obviously that is part of our services for people with disabilities. So I think in general a very positive report. I think the decision to close day services in the first place during the pandemic was not an easy one, but I think from crisis comes different options and different models, and I think the fact that when you hear from people who are using the service and from families that actually very much that community-based service alongside a building-based service is what they want for the future. I think and that we're in this paper able to respond to that. I think is really positive. But you know, enough of my thoughts on it. I'm going to open it up for any questions or comments, and I'll bring in Anne.
Thank you, convener. Thank you, Martin. I've had the advantage of a full briefing from Martin prior to the meeting, so thank you for that. And it means I'll ask a lot fewer questions. But just one thing occurs to me. It says in the report that there were 32 service users over 8 meetings. What's that as a proportion of the overall number of service users? Do you know, or does Margaret know?
Margaret.
I'll come in there. Excuse me. So that, yeah, there was 32 service users, and that's about 65 to 70% of the service users that attended the service that were involved. Although some people didn't attend the meetings, there was questionnaires sent out as well, because we wanted to include as many service users as possible in this engagement event.
I just want to compliment the staff on that extensive consultation to reach and get responses from that proportion of service users is commendable. And I mean, I'm finding this a really difficult report, because it seems to be almost a win-win-win situation, and we don't often get that in the IJB. And I'm still looking for the flaws. So thank you very much to the staff and to the service users who have engaged with the staff on this to come up with what appears to be a solution that suits everyone concerned, or the vast majority.
Thank you. And are there any other comments or questions, Gordon?
Yeah, can I just echo comments around the quality of the process here? It's good to see that has gone into it. It all seems really sensible to me. I think I was looking for flaws as well. It seems really unusual that we come up with a solution that both saves money and actually is what people want. But that's great to see. Just one question. There is, in the staffing establishment, there is a kind of cryptic reference to a half post from HO 999. Could somebody tell me what that is?
That's referenced a specific post number. Each post has a specific ID, so that's just a post number for in terms of the budget realignment. I'm not sure if that answers the question or not.
No, just because all the other posts are laid out there, day centre assistant, day centre officer, etc. I just wonder why that one is coded in that way. I mean, I'm sure there is some technical reason.
It's really 007.
It just seems odd that one is given in a very different way from all the rest.
I think it was simply because it was a post that was being used as part of the overall establishment, but it was sitting in a separate cost centre. It just hadn't been formally moved. I'm pretty sure that's the answer. Just to let you know, just that there's. But I think that's why it's just been separated there, so that we knew it was coming from a separate cost centre.
Any other comments or questions? No. In that case, we could take you back to the recommendations. Are we happy to approve the model of service and agree the closure of Oswald Avenue as the day centre resource, noting that there'll be a scoping exercise around its future use? Okay with that?
Agreed.
And just to note, the proposed building adaptations of Dundas Resource Centre, etc., and instructing the Chief Officer to issue direction. So we always need to make sure that that recommendation is in. So thank you, Martin and Margaret.
Thank you.
No relations. Thank you very much. I'm going to give us a short comfort break just now, just check my watch. So if we can come back in 10 minutes, so that would just be about 11:15. For those online, if you just mute and switch off your cameras, but don't leave the meeting. Thank you very much. Welcome back, everybody, and I hope you managed to get a cup of coffee or a cup of tea and we stretch the legs. So I'm going to just move us along on to our next paper, which is on the IJB governance, and that's Nicola Jones.
Thank you very much, Chair. For those of you who don't know me, I'm Nicola Jones. My substantive role is around primary care transformation, but for the purpose of this paper, I've been asked to do a bit of work around the IJB governance by Gail as Chief Officer. Firstly, I'd like to extend my thanks to colleagues who have contributed their time and expertise to the paper, Suzanne Thompson, Jim Miller and Jack Frawley. And thanks to all of you IJB members for your contributions to the 2 workshops that have informed this proposal. The paper outlines proposed changes to the IJB governance structure, as well as a number of other adjustments, including the increase of frequency of IJB meetings. The proposal aims to ensure that the IJB is able to meet its requirements in the most effective and efficient way. It's proposed that the IJB meets 6 times per year instead of 4, to enable the board to make timely decisions on evolving issues. The proposed timetable is shown in Appendix 1, and thank you to those who have pulled that together. It's no mean feat with all of the various commitments across the NHS and Council, so thank you for that. It's also proposed that the IJB approves the establishment of a new Performance, Audit and Assurance Committee and stands down the existing Audit Committee and the Clinical and Care Governance Committee, effective from the first meeting of the new committee. The ambition is that the new subgroup is an intelligence and data-driven group that has the right level of scrutiny over directed activities, and that they're able to take items in private where they contain confidential information, but require more in-depth discussion by the group. The IJB is also asked to nominate the proposed membership of the new committee. The IJB is asked to agree the proposed membership and of the new committee and nominate members. As part of this paper, the board is asked to approve changes to the IJB standing orders. The only change to the standing order is the area around the clinical care and governance and having the ability to take some items in private. The board is asked to agree that a detailed review of the standing orders is completed and reported to the IJB in June 2025. The report updates the board that current care representatives have indicated they're resigning from their roles, and work is ongoing to recruit those vacancies. This should be concluded by the end of January 2025. The board is also asked to agree the process for recruiting service user vacancies for the IJB. The board is also asked to note that the Energy and Climate Change Coordinator from Falkirk Council will submit the IJB's annual climate change report to the Sustainable Scotland Network by the due date. And that's all I'm going to say. I'm happy to take any questions, and Jack and Jim are also here to answer any questions that you might have.
Thank you very much, Nicola, and also thank you to Suzanne, Jim and Jack as well. I know it's no mean feat going anywhere near standing orders, but I'm glad to see it's just one amendment. I think Anne and I both bear the scars, and Jack, I think, of amendments to the council standing orders. So thank you very much. I'm just going to go through each item, and if there's any questions on each item, I think that's probably the easiest way to do it. So each recommendation. So the first is around agreeing the proposal to increase the frequency of IJB meetings from 4 to 6 per year. I think that's a relatively straightforward one. I think pretty sensible given the amount of activity that we have as an IJB. I'm going to ask Anne if she has a question here.
Not so much a question, it's just I think it is a good idea. I have been concerned that sometimes we don't get a chance. It's too long between meetings on really important matters. So I think that is a positive move. What I'd also say is, can we have thinner agendas as well.
Well, I think that's a good plea, and I think we have quite a short agenda today, so I think quite useful. Caroline.
I just wanted to say, as a CARE representative, whilst I understand from a board perspective that more meetings is definitely worthwhile and would be very useful, from a CARE representative perspective, it's actually quite an onerous thing. The reading of the papers takes like forever to do, and then even just this week, for example, I've got this meeting today, which is likely to be 3 hours, and then Monday I was at Carer Voices, which was 2 hours, so that's 5 hours out of my week as a full-time employee that I'm having to find to try and do this. So just my plea would be, when you're looking at who's going to replace myself as the carer representative on the IJB, that there's consideration taken to them having actually the time to do what's required. Thank you.
Yeah, and I think that's a really important point around ensuring that there's support and the time that it takes to be involved in the IJB, and you know, very well aware of the amount of time that it takes for the preparation. So thank you for raising that point, and I know that that's part of some of the discussions around supporting carer reps and service user reps on the board. So I think, I suppose, just can I ask, are we happy to approve that recommendation?
Agreed.
Agreed, right. Our next point is around establishing a new performance audit and assurance committee. So first of all, I'll ask if there's any questions in relation to that. No. Sorry, Margot. My apologies.
No. Just to check what the actual remit of the new proposed performance audit and assurance committee will be.
Nicola?
So it combines the existing committees, as in the current audit committee and the current clinical care and governance committee. So it would have the functions of both of those committees together, and then we've also added in the additional performance element, so to have an overview of performance across the areas that the IJB direct. So that would be the main remit, and the terms of reference for that group would be developed as part of the first meeting of that group and agreed as part of the first meeting of that group. So that's where you would get the kind of more detail.
So is clinical governance really going to be performance or assurance?
So I suppose that's just a title for the meeting, and without putting about 10 words in, the assurance part of that meeting title was intended to incorporate that clinical care and governance part, but it absolutely will be a critical part of that meeting and will be clearly set out in the agenda.
Thank you.
Thank you. And Anne?
I'm just wondering if it might make sense to take 2.2, 2.3, 2.4 together, since they are all interrelated. It's as the chair of the Clinical Care and Governance Committee, I am absolutely in favour of this merger between the Clinical Care Governance and Audit Committee, which is in effect, as I understand it anyway, what is happening, and that will it will reduce the amount of duplication, I think, that we have experienced, which is time wasting. It will reduce the need for extra meetings, which is time wasting. So I think it does make sense. Also, the increase in the number of voting members on that committee. I know that there was a situation where, for personal reasons, I wasn't able to be at a committee, and the end result was the committee had to be cancelled because there weren't enough voting members able to be there, and that's a waste of everybody's time. So I think that putting the two committees together makes a great deal of sense. It will not reduce the areas of activity that are being addressed in any way, but will hopefully do it more efficiently.
Great. Gordon?
Yeah, I mean, as chair of the current audit committee, can I just concur with Councillor Hannah's comments, particularly around in what effectively became a quorum of one member. You know, there were times when I was conscious that I was the only member at a couple of meetings and was in the position of taking basically whatever decision I wanted on behalf of the IJB, which is great power, but not a comfortable position to be in. The other thing I would say is I take the point that we don't want to end up with a title that's you know, audit and risk and clinical governance and whatever, but just not to forget that risk is an important part of the work, but I'm sure that'll come out in the terms of reference when they're drafted.
That's great, thank you. So I don't know if there's anyone else wants to come in. Roger?
I was just questioning why although the number of voting members has increased, you haven't considered the number of non-voting members there, given the merger of these two committees.
I'm not entirely. So I'm not. Can I just double check what the question was there again? I didn't quite catch it.
The number of voting members in the committee has increased to 4. The number of non-voting members in this merged committee it remains at 2, and I'm just aware for the same reasons that 2 could mean that neither a non-voting member would be attending due to sickness and things like that.
I don't know if Nicholas.
I think it's a fair point. I guess that's what the minimum is. If more non-voting members want to nominate themselves as members, they could. But take the point that I think that's a relatively easy change we can make in the terms of reference for that. I don't know if there's anything technically that we would need to do to change that.
No, if the IJB was agreeable to increasing the number of non-voting members on this new committee, then there's nothing to stop them doing that, if agreed.
Could I suggest then, in relation to staff side representation, that there's somebody from the health side and somebody from the council side and somebody from the third person from representing service users?
What can we just check what the process is around this? Gail, do you want to come in?
Yes, so my understanding is what we're seeking to agree today is that we agree to the establishment of the committee with the membership as set out in the recommendations. The first meeting of that committee, which is planned, if this is agreed, to be in the middle of January, will go through the terms of reference and agree or not. So I'm just wondering if that might be a good conversation to bring into that first meeting, and then if there's a proposal through that conversation and the review of the terms of reference to actually increase the number of non-voting members to a specific number, thinking about who they might represent, for example, that could be incorporated, because the proposed terms of reference then would come back to IJB in January for approval. So that gives a little bit of time for colleagues to have a think about it. So it doesn't stop us agreeing the recommendations in the report just now, just checking that I'm correct. But that then would allow for a different decision to be taken around the agreement of the terms of reference at the end of January.
Are you okay with that approach, Roger, that the first meeting of the around the terms of reference will consider who should be involved?
It's a bit chicken and egg, isn't it? Because if you don't agree who the membership is, then who's at that first meeting to have that discussion?
Yeah.
Thanks, Chair. I wonder, as some advice, would it be agreeable to adjust the recommendations at 2.4 to agree the voting members and to then agree that the non-voting members will be discussed at the first meeting, and this will be returned to the IJB after that meeting. So we're not agreeing the non-voting member position at this meeting, but that will be agreed at the next meeting.
Just to add to that, what we could say, so at the first meeting, then any and all non-member would be invited to that first meeting. That'd be acceptable.
Does that kind of get us to the it gets us to the point where any non-voting member can be involved in that first meeting, so we can then come back with proposals around the different non-voting members to be involved. Does that sounds like a plan? Anne?
I think that sounds right. Can I just have clarification, because I was not. Is this reducing the number of non-voting members who are engaged here because we're increasing the number of voting members? No, I didn't think so. That was where I suddenly started to get concerned that we might be somehow reducing the non-voting members. But if not, then yes, I think the proposal that's been put forward is fine.
And we can obviously make a note round to all members of the IJB regarding that first meeting, that it is in an open invite for non-voting members in terms of agreeing the terms of reference and the membership of that committee beyond what's set out here. Okay, so unless there's any other questions, I'll be happy to agree 2.2, 2.3 and 2.4 around establishing the committee, standing down the audit committee and clinical care governance, and agreeing the membership. Margot.
Sorry, the daft lassie question again. What do you see the role of the service user rep to be on the new committee?
I'll go first, and you can add if there's anything that I miss. I think that again would be part of the development of the terms of reference, and I guess the discussion with that service user rep about what commitment they could allow. I think there are probably detailed discussions that we need to have following this agreement, would be my view.
Right.
Yeah.
Yes, thanks, Chair. So, Margot, currently in the proposal here, there is no, the service user rep was not a position which is set out in the recommendations. It was just non-voting members, so that could be any non-voting member of the IJB. If at the new committee's first meeting, the agreement is that they wish for the service user rep to be a part of that committee, then that can be agreed at that first meeting, in which now all non-voting members will be invited to the first meeting to discuss those terms of reference.
Right. Was it the meeting of the Alliance, which is a sort of IJB union, I think you would call it, and they were discussing this whole issue of voting and non-voting, and whether really service user representatives should have a vote. So it's quite a big issue to me, and I'm sorry to keep going on about it, but it's just, I'm not quite sure of the future value of the service user reps, although I think they are central to the work of any IJB checks and balances and all that. But I think, you know, it's just a sort of slight niggle at the moment, but I'll give it lots of thought. Thank you.
I would come in on that, saying that I'm aware of those discussions, and I know that some of the work around the National Care Service was around changing who could vote so that it wasn't restricted to the two statutory partners but was extended out particularly to include service user representations and representatives and carer representatives. I will say I'm not quite sure whether that's that, given the uncertainties around the National Care Service Bill, but there does seem to be some keenness at a national level in ensuring that bit is, whatever happens with the National Care Service, that the good bits that everybody agrees are good bits, and that's one of them, aren't lost.
Yes, the bill at the moment's kind of
paused. I think it's the word we look for. Paused. Hopefully we'll have more news on that in the not too distant future. So I think just in terms of the non-voting members include carer and service user representatives, but we haven't been specific there. But just in terms of that point around agreeing the membership, is there just I'm just looking at Jim just now, just a slight amendment to that to say that the representation of the non-voting members will be decided in the terms of reference at the first meeting,
which will then be presented.
Which will then be so you could get the right words in there for the minute. But are we happy to agree that principle?
Just to be absolutely clear, are we agreeing a number of non-voting members today, or are we leaving that to part of that discussion as well?
Yeah. I think we're leaving that to that discussion.
Yes, that's correct. Yeah. So no non-voting members agreed today. All invited to the first meeting, which will then be agreed and sent back to the IJB for final approval.
We're okay with that. Thank you very much. And then I'm going to move us on to a 2.5 and kind of 2.6 kind of comes in with this as well. 2.6, before we nominate members, that the agreement of whichever constituent party, so either the NHS or who is the chair of the IJB shall not be the chair of the Performance Audit and Assurance Committee. So basically, I hope I'm summarising this right. When the chair is held by the council, it's the NHS who would hold the chair of the Performance Audit and Assurance, and vice versa when it's the other way around. So just checking I understood this okay. So are we happy to agree that recommendation, and then we'll move on to nominations? Okay. So I just need to get to the right bit on my paper. And I've lost it again. I've lost it. Where are my? Oh, right. My pages are sticking together. Could be my hands. Here we are. Okay, so we have to nominate the voting members of the from each constituent party. So that is 2 from the council and 2 from the health board. And obviously, in the position of being the chair of the IJB, it's not me. So I'm going to take the opportunity to nominate Councillor Hannah and Councillor Flynn, who unfortunately has had to leave the meeting, but we did have the discussion in advance with him about whether he was happy enough to be nominated. So I'm happy to nominate both those councillors. And I'll nod to say she's quite happy with that. I'm going to open it around the nominations around the NHS. Michelle?
Thank you, Fiona. I would like to nominate Gordon Johnson and Stephen McAllister.
Thank you.
And both of them, I understand, are happy to be nominated. That's
okay. And there's nods of heads. Thank you very much. I don't think there's any other nominations in relation to that. And I suppose that the question around the nomination of non-voting members. I know there was some interest in becoming involved, and I don't know whether we need to now take that decision around the non-voting members to that first meeting of the committee, which will be open to all, and bring that back to the next IJB thereafter. Is everyone okay with that? Good. We'll get through this. Right. Easy one. Agree the programme of meetings for 2025, and I do not doubt the challenge. I have a challenge of organising my own diary, and I have no idea how anyone manages to get a programme of meetings out of all the different things. So are we happy to agree that programme of meetings are, is there anything anybody wants to highlight that they haven't already? No? Oh.
I'm assuming, Chair, they're all 9:30 starts.
So correctly, all 9:30 starts? Yes.
Ish.
Ish. Okay. Stephen.
Muted, sorry. Yeah, Fiona, just a quick one. There are already a couple of clashes, as you can imagine, with some of the health board stuff. We did flag that up earlier on in the week. We didn't have the IJB meetings as yet, but I think it's just a case of getting them into. I know the plan is to create an overall planner across health and the respective IJBs. There will be clashes, but it's just so we're given as much advance time as possible to either avoid them or to nominate substitutes, so we're not in an issue that we find ourselves that we're not quoted. So I'd welcome that, we've got the dates in advance now and getting them across to the health board, and we can create that planner. But thank you.
Yeah, I think that's absolutely the case, Stephen. I think there will be points where there will need to be substitutions in it, and I think with the best will in the world, that will happen. So thanks very much for flagging up, and I think I always like the early notification. So though I don't really like starting to plan a diary for next year, it's not, no. But has to be done. So so we're happy to agree those programme meetings. 2.8 is approving the change to the IJB standing orders, and I've got that on page 174 around, and that's about where there may be matters to be discussed related to clinical and care governance, where the public may be excluded from the meeting. And I think that would be in general kind of limited, but practice where that is required. Are we happy to agree that? Yes.
Agreed.
Thank you. And approve the proposal to discontinue the sharing of joint staff forum minutes, and there'll be updates from the joint staff forum chair when necessary. Roger.
I agree that the minutes don't need to be shared. I just felt that there was a period when the joint staff forum was actually being cancelled quite frequently, and I think it's quite important forum. So I think it'd be important if, just to get a note that these forums have occurred to the IJB. I don't know if that would be agreeable.
Okay. Yep. I know that. And note the works undergoing to identify carer representatives on the board, and Carol, and I noted and extend our thanks around your offer to continue to support and help with that handover. So thank you very much for that. And there's a process. 211 is agreeing the process for the recruitment of service user vacancies on the board as they arise, as set out in section 4. Are we happy to agree that?
Agreed.
Agreed. And the last one's a noting, and we'll have an annual climate change report submitted by Falkirk Council on behalf of the board.
Agreed.
Nothing we need to agree there. So thank you very much for that. And it always takes a wee while to get through the technical changes, and thank you, Nicola and the team, for all the work on getting that ready for us. I'm going to move us on to the performance monitoring report, and that's Callum.
Thank you, Chair, and good morning, members of the board. I'm going to give a quick overview of the content of the latest iteration of the performance report, and then I'll be happy to take any questions or comments that you might have. For this iteration of the report, performance is reported up to September 24, and with a year-on-year comparison. The report has a focus on exception reporting, and I'm now just going to talk briefly through some of the areas highlighted in the exception report. The report highlights there are continued pressures around emergency department 4-hour compliance and around delayed discharges. Compliance against the emergency department 4-hour access standard was at 46.8% for September 24, and that's compared with 48.6% for the same period for the year before. There were 65 delayed discharges at the September 24 census, which is just one less than for the same period last year. The overall position remains under continued with sections 5.1 and 5.2 of the main body of the performance report, which can be found at page 197 of the packs. And there you can find further details as well as some of the actions ongoing to support these areas. The report details for both Falkirk Council and NHS services the number of complaints received and the percentage responded to within timescales. For Falkirk Council, a total of 73 complaints were received in the first half of the year, with 74% responded to within timescales. For NHS services within the partnership, there were 22 complaints received and 36.4% were responded to within timescales. There are detailed exception reports for sickness absence across both Falkirk Council and NHS services attached to the partnership. For Falkirk Council, absence for the first half of 24-25 was 10.7%, which is a small decrease in performance from the equivalent period the year before when the figure was 10% exactly. For NHS services, the overall September 24 sickness absence position is reported as 8.31%, and that's compared with 6.07% in September 23. And just to note that prison healthcare and primary care moved to sit under the partnership in the December 23 for reporting, and therefore the data for the most recent time period isn't currently directly comparable to the year before when they were not included. The report details the latest position for waiting times for psychological therapies, and in September 24, 79.8% of patients started treatment within 18 weeks of referral. That's an increase from the previous month position of 70.9% and an increase from 67.1% in September 23. And just lastly from me, the previous two iterations of the performance monitoring report have included exception reports for indicator 68A, which relates to alcohol and drug treatment waiting times, and that was due to a decrease in performance. I'm pleased to report that performance is back above the national target of 90% of patients will start treatment within 3 weeks of referral, and therefore no exception report was required this time round for that area. In terms of recommendations, the board is asked to consider and comment on the content of the report and to note that appropriate actions continue to be taken to address the issues identified. Thank you for listening to the update, and I'm happy to take any questions or comments that you might have.
Thank you very much, Callum, and I think those points about improvements in performance around those that initial access around drugs and alcohol, but also the improvement around psychological therapies. And I think anybody who saw the census results around, I suppose that the impact of mental health across our whole population, and how important that access is, alongside a number of other things, but how important that is. So it's good to see it heading up the way, that access for individuals when they need it. I do have one question, and I suppose it's maybe just it might be a comment. It could be a question if anybody wants to answer it. It is around sickness absence, and I suppose that kind of stubborn trajectory, where I think there has been points where there's been some progress made, but other points it does seem that sickness absence is not able to be brought down anywhere near the target. And I wondered if anyone had any thoughts or comments, or maybe even just some discussion on the work that's ongoing. Gail?
Yeah, I'm happy to start on this, and other colleagues might want to come in as well in terms of local actions that have been taken. So I think it is stubborn is a really good word to use, and we do see continuing high levels of sickness absence across both NHS employed colleagues and council employed colleagues. It is something that's we get a lot of support on from our HR colleagues from both organisations around, particularly around the longer term absences in terms of going through the processes. In addition, it's on our radar in relation to our financial budget planning, recognising actually that's an area of spend, which actually if we had a lower sickness absence level, that would be reflected in terms of lower costs for delivering services. So it's really important from that perspective, as well as from the wellbeing of the staff perspective. One of the things I would say is in terms of what we see locally in Falkirk isn't largely dissimilar to what we see elsewhere in Scotland in terms of the workforce. That being said, it's still important that we do continue to do everything we can to support people to come into the workplace and support them to do their valuable jobs. I'm just wondering if any of our heads of service, operational heads of service, want to come in to talk about anything else. Yep.
Thank you. Through yourself, Chair. So Callum mentioned that these most recent elements of data now include prison health care, excuse me, primary care. I don't know in terms of the detail of whether or not that's seen itself as a spike, but I wouldn't be surprised if prison healthcare in particular didn't contribute to a significant spike. People will know that we have 3 prisons in Forth Valley, obviously Stirling, Polmont, Glenoakle. They're challenging times at the moment in terms of prison populations and quite a flux in terms of changes of prison populations, and a significant spike in the amount of people who are now in Polmont prison because they have kind of reconfigured it and they're now bringing in a very different population. That has been quite a challenging time in what's already quite a difficult environment to work in. Now, of course, that means that we're going to have to address that, but I suppose it was just by way of acknowledging that at the moment, and what I believe is a moment in time, because largely it's a very good performing sector, that we are having some challenging times in terms of attendance in the prison sector, and I think that's probably where that spike mostly sits in relation to the recent data.
Thank you for that, and it's really helpful. And I think, especially when we start to look at things like agency and bank spending and stuff like that, that point around the, we can really support people, and I think that's the point really about really supporting people in the workplace and supporting people to get back into the workplace. I think is really important for our services, but also for the individuals themselves. I'm going to come to Stephen and then to Caroline.
Thanks, Fiona. I can hear my own voice, so that's not great. But yeah, so I do quite a lot of work in organisations in terms of wellbeing and management of absence, and what a lot of commercial organisations have found recently, particularly post-COVID, is the self-diagnosis of.
You've muted there, Stephen.
Oh, apologies. Can you hear me now?
Yes.
Yeah, sorry. Yeah, so I do quite a bit of work commercially with organisations in relation to wellbeing in the absence of management, and a lot of organisations have found, particularly post-COVID, the self-diagnosis of either a mental health or a physical health condition, and actually it's given them huge problems in terms of managing their absence, and actually they've had to find a way of navigating their way through that self-diagnosis. So I'm wondering if we have the figures, and probably won't have at the moment, but there's a bit of work we can do around about how do we manage self-diagnosis? Because actually in some organisations, they have found that by managing that much more effectively, it brings the absence figures down. And the second part of that is our return to work processes have to be really on the money. A lot of return to work processes can be quite kind of just tick box situations as well. But so I'd like to know a little bit about what they're looking at. Sorry, somebody's at my door. My dog's just crazy. About our the self-diagnosis and also return to work interviews. Thank you.
I'm going to open up to Gail.
In terms of the question about self-diagnosis, I think that's something we can take back to our HR colleagues to understand more about what that data looks like and how that's gathered. In terms of return to work, again, both organisations have a return to work policy, so people coming back to work will have an interview with their line manager, which is captured, which seeks to understand whether or not this was a one-off, whether or not there's something underlying that, is there something that we can do as an employer to support the person depending on what the situation is. So there's quite a robust process around that. And as I said, our HR colleagues do support managers around people who maybe have conditions that result in multiple absences or longer term absences.
Thank you. Caroline.
Mine is not about absence. Is that okay, just to continue?
Yes, absolutely.
Thank you so much. I was just going to scout the board pack today, and always actually there's lots of information about carers and how some of the decisions are affecting carers. There was a recent questionnaire around about the state pension and carers allowance, and I wondered where to bring this in, so I'm hoping it's okay to talk about it now. Thinking about the way that we see in the board papers that will, in the carer strategy, how we'll support carers, they're feeling really undervalued in respect of the decision to withdraw the carers allowance once somebody becomes state pension age and starts to be in receipt of their state pension. They're feeling really upset and unappreciated. I know this is not something that you can change, but I'm hoping that by raising it here, it could be escalated. Some people are having to, not remain in work or take early retirement in order to continue caring for their loved ones, and this financial burden is just adding to the levels of stress and anxiety and mental health issues. They are already struggling, and they continue to care once they've retired. So, that's not stopping. I've got pages and pages of feedback from carers about how unhappy they are about that. So I just wanted to raise that in this forum. And then the second thing was around about older carers just leading on from becoming state pension age. They're also really worried about the lack of future planning for the disabled young people as well. So that's also coming out in some of that information. Thank you.
Thank you very much, Caroline. And I don't know if you want to, I suppose maybe the stuff about future planning, if there's somebody around the work, any of the work we're doing with the carer centre.
Yeah, so I'll maybe talk about future planning and then maybe ask Caroline to come in. Caroline's been doing a lot of work with the carer centre over the last couple of months. So in terms of future planning, we're obviously doing a lot of work at the moment in terms of the current challenges we have particularly around finance. Moving forward during 2025, we're really keen to take a collaborative co-production approach with a range of stakeholders, including workforce, including partners such as third and independent partners and carers and citizens themselves, in terms of thinking about what we know in terms of our projected demographics, in terms of our projected finances we might have available, in terms of the current workforce and what we might need to start to work on developing a future operating model. So that would define in a little bit more detail in terms of the areas of investment that we'd like to see. So in terms of the conversation we had earlier on around the importance of early intervention and prevention, we all know and we're all in agreement, and that's really, really important. But how do we protect what we invest into early intervention and prevention to hopefully help people to stay well and independent for as long as possible? So we want to embark on that process during next year. Again, there will be difficult decisions required as well. Not everybody will agree with that, but we're hoping that through taking that open, transparent, participative approach, people will at least understand the whys and understand why we need to move forward in this way. So that work will then underpin the next strategic plan for the IJB. So the current strategic plan takes us through till spring 2026. So the work over the next 12 to 15 months will underpin and will become that next strategic plan. So we're really keen that we have the people feel that they have been listened to and have the opportunities to have their voices heard as we go through that process. But maybe Caroline might want to say some more around work that we're doing at the moment with carers.
Thanks, Gail. If I can just pick up the second point that Caroline talked about, like it was more around, I think, like, you know, transitions and planning, you know, for people that are currently being supported, mainly by their carer, unpaid carer, family member. In terms of transitions, what we're doing is we've had that as a test of change, had a transitions team in place. That's predominantly looked at supporting young people through that transition from school into adult services. We're currently reviewing how that's operated and looking at developing a strategy really around how we'll support, you know, young people through that process into adult services. We're probably, you know, just right at the start of that process, Caroline, but we'd be keen to, you know, really make sure that we're involving carers in developing that process. And it kind of links with the learning disability strategy, which is currently being developed. So there's a range of work that's going on, and it's just really to provide reassurance that we are looking at it. And we will make sure that we're involving all the key stakeholders within that process.
Just say thank you so much for that, and also I should have mentioned at the start that they were also really appreciative of yourself and Gail attending the Voices meeting on Monday too.
Thank you, Caroline. And I'm going to pass to Anne now.
Thank you, convener. Just first, I wanted to take a step back to sickness, absence, and ask whether in the future there could be, when you're looking at this, you look specifically at the distinction between the level of short-term and long-term sickness absence, because there are very different reasons for the different levels of absence, and I think it's important that you tease that out. The other thing, I mean, obviously we're pleased in the areas where there has been an improvement in performance, but I just wanted to highlight and ask for a bit more information about the emergency department and the 4-hour access standard, because clearly that's a significantly low level of performance and the deterioration in the performance. And I think we need to know what actions are being taken to try to address that issue.
Okay, thank you. So it's a bit like the conversation we had on delayed discharges. It is really stubborn. There's a huge amount of work that's underway, and again, it's really important to stress that the 4-hour access standard is an indicator, and it's just one indicator of our whole system and what's happening across our whole system. So there's a number of different things. It's not about how well the people who happen to work in the ED are working. It's about how actually what pathways have we got in the community that people can receive support as close to home as possible. What flow do we have across the whole system? So it is a very stubborn indicator. There's obviously been a huge amount of focus on that across NHS Forth Valley and both partnerships in terms of how we support that to improve. There has been some improvements, but it just takes a few days with a lot of people turning up at ED. So I think last weekend was particularly busy, whereby they were over capacity by 70, 80, 90%, and it's really difficult in that situation. And that then has an impact on that whole system flow and everything else in the system. So one of the things, and this doesn't change the experience that people receive when they need emergency department support. But there is at the moment, the way NHS Forth Valley indicator is gathered, it includes performance for the ED in Forth Valley Royal and there's a separate indicator for the minor injuries in Stirling. So the minor injuries service actually performed really, really well. It's pretty much close to 100% consistently. It might be 99 point something percent, but it performed really, really well. But there's going to be a change to bring both of those indicators together, which will show a difference, but that doesn't improve it from a person-centred perspective. But I suppose just again for colleagues' information, from an NHS board perspective, it's a consistent item of discussion and interest and scrutiny and engagement. So there has been some little positive parts to that, but overall the performance has remained very, very stubborn. But we continue to focus on that and work on that as a whole system. I think there's a lot of work on processes and systems. I think the cultural element is really important, and that might be from a cultural element in terms of the workforce as well as citizens, in terms of how we use and think about accident and emergency services as a citizen as well. So there continues to be a big focus on that.
Thank you. I mean, I recognise that it's a whole system question, and it links in with what's going on in primary care as well as what's going on within hospitals. But it is a stubborn and very concerning area.
Yeah, can I just say, I mean, I agree entirely with everything Gail has said. As non-execs on the health board, it's something that we have questioned over years now. And the real frustration, and I know it's probably even worse for the people who are working there, is that we keep seeing plans coming forward. We keep thinking that's all the right things. In fact, the latest plan that was put in place was assessed by the Centre for Sustainable Recovery, and they said that it should lead to something like a 15% performance improvement. So we're kind of doing the right things. We're being told we're doing the right things. The experts are saying we're doing the right things, but the figures are kind of stubbornly refusing to move, and that's the frustration right now.
Yep. Just to add to what Gordon said, so obviously NHS Forth Valley has been in escalation stage 4, so it's had a lot of scrutiny and support from a range of different agencies, including national, and consistently what we're hearing is what we're doing looks to everybody to be the right thing, but the stubbornness is it doesn't seem to be making the impact that everybody expects it. So it's not like we don't have good plans, we're not doing the right things, but there's something else that's stopping that. And we do think that a big part of that is around the cultural, the softer elements that are harder to shift. Tom?
It's interesting that about the conversation, because I referred to this earlier on in terms of this sense of, well, we know what's right and how we fix it, and we have a systemic approach to it. Why is it not working? Because I don't think what we're adding to this is the behaviourist element of this. Is that why are people doing things which might seem counterintuitive? Why are people not just doing the normal and the obvious things to do? And that's because the circumstances are not there for them to do that, or they're not fully kind of grasping it. So I think it is about behaviours. It is about starting to address that as kindly as you can, but as forcibly as you can, about choices that people are making and the decisions that are being taken. Because I think if you look around the system, the ideas are all there. The analysis is all there. Everybody knows what would make a difference. It's just getting it to connect with frontline and also the public, etc. And I think it's just about shifting the dial on some of that.
Thank you, John.
Thank you.
I've got Stephen.
Yeah, thanks, Fiona. I just think, and trying to put a little bit of good news in this. I mean, I think one of the, Tom's point about behaviour is the behaviour approach is really important. But I think we struggle in Forth Valley because we have one ED, and it seems to be a single point of failure for us. If you look across, I think Glasgow's got at least 3. There will always be an ED in Glasgow that is really struggling, but actually the performance across the 3 kind of pulls that up. And also, you can go somewhere else if there's a particular queue at Queen Elizabeth. You can actually you can be redirected, and it happens with the ambulance service. They get redirected, but we don't have that facility, and I think that's part of our issue, which is systemic. But to just reiterate, I mean, we have looked at this since I've been on the health board, and we are doing our best. and we don't seem to get a lot of traction on it. So we continue to do our best in that area. But actually, if you look at our minor injuries performance, is outstanding. And also, if you look at the way that the use of NHS 24 and 111 in Forth Valley, the pattern is slightly different. It's actually used very, very well. And if you look at how we work with the ambulance service, so there's lots of good stuff there that we don't necessarily see on that performance report. But yeah, I think that single point of failure in terms of the 1 ED is a real challenge for us going forward.
Thank you, Stephen. I'm just going to say, are there any other comments or questions? Ian?
Thank you, Chair. Just a quick question, and it's not a third sector one, more of a passion for service type question. A recurrent theme for me seems to be the complaint handling. When you look at overall performance of an organisation, how they handle complaints is a really good indicator of how service is within the organisation. And I noticed that performance in terms of responding to complaints within timescales is really poor. Of 13 complaints in the last 6 months relating to the partnership, none of them were actually responded to within time. And on one hand, the narrative talks about workforce pressures within the patient relations team, but on the other hand, it also talks about overall low complaint handling, low complaint numbers. So I just wonder if there's anything that's been done to focus on that area, because it's really small numbers in comparison to some of the other stuff, but it's a really important area to get right in how we respond to complaints.
So just to say, again, this is an area of focus in the partnership, and currently, in terms of the talk about committees, the Clinical and Care Governance Committee receives a regular report on our complaints handling performance and scrutinises that and seeks assurance around what we're doing to improve the indicators there. So there's, again, like everything, there's a number of different factors that will impact on the performance there. I know in terms of from a Forth Valley perspective, at the public session yesterday, the Executive Director of Nursing was highlighting the fact that there's additional capacity being brought in to support that, and some of the challenges in terms of all the stuff that colleagues need to do does impact on that performance as well. But it's something that does receive a lot of attention through management and from the committee itself as well.
Thank you. Any other questions or comments? No, in that case, I'll take us back to the recommendations, which are both consider and comment and note. Thank you very much, Callum. Much appreciated for you presenting that report. And I'll take us on to our communication and engagement update from Paul. Thank you, Paul.
Thank you very much, Chair, and good afternoon. So you'll know that I am here to present the quarterly update, which provides ongoing monitoring of the implementation of the partnership's communication strategy and its participation and engagement strategy and the joint action plan. So the content of the update covers the period July to September 2024. And during this period, the partnership received at least 6 pieces of media coverage, totalling a reach or opportunities to see value of over 57,000. And coverage was received in the Falkirk Herald, Falkirk Live and Daily Record. And this includes news of the relaunch of the Dollar Park Dementia Service following its refurbishment and its expansion of evening and weekend support. News of a series of hands-on tech library sessions which help people understand the range of technology that's available in their own home that could help them live more independently, and news from the last IGB meeting on the decision on garden aid in September. The partnership held or attended 11 engagement events, meetings and drop-in sessions during this period and involved 245 people. This engaged across a range of service areas with the 4 surveys open during this period, covering digital and health care delivery plan, the second phase of engagement to draft a Falkirk Learning Disability Strategy, and the Forth Valley Palliative and End-of-Life Care Strategic Plan. And a full list of the media coverage received, events held and consultations open during this period is provided at the end of the report. The report also includes a summary of internal and training and workshop activities that took part during this period, including the first meeting of the Alcohol and Drug Partnership's Authentic Voices Group and the first carers representative training sessions, which took place in August and September. which advance the range of opportunities for people with lived experience to take part in the design of services and decision-making processes. In terms of upcoming activity in the next period, as discussed earlier today, we'll be going out to consult on our budget process, and the communication about that will go out imminently as well, so that we're communicating in advance of those opportunities being available. In the next period, we'll also cover the development of locality plans for Central, East and West, and the development of a Forth Valley-wide mental health and wellbeing strategy. So that's it for today's report. So I'll return to the recommendations, which are just to consider and comment on the report. Thank you.
Thank you very much, Paul. I came across a question as this meeting has gone on, and there's been two discussions around future planning. One was around palliative care, and one was around older carers and future planning around our adult child. And I know that there's a national campaign annually, and I don't know which month it's in, around power of attorney. But I wondered about wider communications, about supporting people to plan for their future and linking them in with resources that are available. So, for example, I know that Strathcarron has a booklet that can help you plan if you've been diagnosed with a life-limiting or terminal condition, to be able to set out what you want. And I just wondered, are there other resources that we can link people in the area in with?
Of course, yeah. So the Power of Attorney campaign that you mentioned, it is February, and I've actually got a meeting in a few weeks' time to discuss our local activity for that. So I can bring those sort of comments in, and we can look at promoting it more widely, rather than just the national campaign in February. But yeah, that's definitely something that we can consider.
Okay.
See, talking about the power of attorney, because I recently did quite a bit of work in relation to power of attorney and created a template for it myself some time ago. One of the challenges that people have, and I don't think this is well enough communicated, is that unless you're given the impression that you really need to go and see a solicitor and get this all drawn up, if you like, but actually there's some really helpful resources online that will actually take you through it, and you just fill in the details, and then the only thing you really need is therefore the kind of the approver status of either a solicitor or somebody in certain jobs like a GP and things like that. And then it goes to registration. That massively cuts down the cost of this. I think the cost can be seen as a big inhibitor, and I think any campaign really needs to be drawn attention to the fact there are really good resources online. It's not that difficult to do. But people are often very much put off by what they feel is a fairly daunting task if they were trying to do it themselves, or a very expensive one. And I think that's something we should be trying to locally feature if we can.
Caroline.
I would just like to echo that. I've been to the Carer Centre run a session on power of attorney and all things around about that, and it did feel like a total minefield. Something that I was really worried about myself. So I think if there was ways to provide that feedback that we've just had there to the Carer Centre so that they can give that to the carers, that would be really helpful, I think. Thank you.
Thanks very much, Caroline. Anne?
I'm just wondering if we shouldn't be looking at putting something onto the Health and Social Care Partnership website that gives that would then give the kind of authority to the process, that because people sometimes get scared about what they find online, can they really trust it, and so on. So it coming from a more authoritative source would be useful.
Yeah, that absolutely makes sense. Yeah.
Yeah, I can probably just add on that the Falkirk Council website is being refreshed at the moment, and the content around adult protection and child protection and things like that will be reviewed as part of that. So there's opportunities soon to add that stuff in. Yeah.
Very much. Any other comments or questions? Online. In that case, thank you very much, Paul, for a really interesting report. And I look forward to hearing more around the stuff around and I still can't remember what what was the campaign called around the power of attorney.
Power of attorney in February. Yep.
Yeah. That's great, thank you very much. So I'm going to just take us on to our final item on the agenda, which hasn't really taken us on to it's just really the approved minutes of meetings, and these are for noting. We don't normally take questions specifically on them, but just to note to you all that they're there, and if there's any comments that or questions that you have, then I'm sure that you can direct by email to the team to get more information. Well, that brings us to the end of our meeting, and I want to thank everybody for attending today. And I'm loath to do this, but I'm going to have to anyway, because it's our last meeting before Christmas. So I know there's quite a while to go, but I hope everyone has a restful and a peaceful Christmas when it comes, and able to recharge batteries a little bit for our next year as an IGIB. Thank you very much.